Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Siegel, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
You can also subscribe to us on Patreon for on-demand content for injectable and business education. David, it's podcast number 5 of the week. How are you feeling?
I'm feeling good. I'm pumped for this one. I was going to say it's Masseter Monday, but it's actually Wednesday.
It's Wednesday, but same thing. We'll pretend it's a Monday. So it's been a busy week for us. We welcome back Dr. Felix Lee, our friend from Singapore, and Stefania Roberts, all the way in Melbourne. We'll introduce you guys in a sec. But in terms of podcast news, we've run out of news because we've done 5 podcasts this week. There's nothing else to tell everyone.
Not really, no. I mean, it's just been a busy week. We've had lots of interesting discussions. We just finished our chat with Dr. Kate Goldie, which was actually our second time round. The first time we had a technical issue. So basically we had a useless podcast. We had to redo it. So it was actually
It was good second time.
Yeah, it was good. I think the second time was even better than the first time. So exciting.
Absolutely. And just to remind you, if you're new to the podcast, we've now divided some of our podcasts up into 2 halves. This isn't one of them. So this one is all free. You'll be able to enjoy this one on your favorite podcast app. But some of our podcasts, you'll notice that there's a part 2 to them. So if you want to listen to all of our podcasts, you can just subscribe to our Patreon.
Yep.
All the details at the bottom of the podcast description. And if you wouldn't mind also subscribing to us, actually following us on the podcast app, it would just help with our statistics so we can work out how we're doing. If you follow us on Instagram at Inside Aesthetics Podcast, and also there's also a link at the bottom of the podcast description for our WhatsApp chat. So if you're a listener and you just want to engage with us or feedback or say hi, tell us where you are, you can also say hi on WhatsApp.
Yes. What are we talking about? I alluded to the fact it's Masseter Monday. What is the topic of discussion? Tell us what it's all about.
Okay, fair enough. So the premise of this podcast, it's MMP, or Masseter Muscle Prominence. Now, that sounds a bit boring, but it's quite exciting. Well, I find it quite exciting. It's the first new on-label indication for Botox in, I don't know how many years, probably about 15 years. So it's the 4th aesthetic indication for Botox. And when I say Botox, I mean that specific brand.
Right.
So if you're using another brand, those are still off-label. So let's introduce our special guests again. Let's start with ladies first. Stefania, you've joined us on the podcast before. We had a great Tox Talks where you had a bit of a battle with Neve Corduff and we were talking about resistance. So welcome back to the Tox Talks. Tell everyone about you, your practice, where you work, and a bit about your background.
Well, it's great to be here again, Jake and David. And yes, last time it was a fight on, fist on with Neve Corduff, who was spinning a lot of, as she would put it, BS, because I think I won that debate. But it's one that just doesn't lose its vivacity at conferences. So that was a lot of fun. Who am I? I'm an aesthetic physician and phlebologist based in Melbourne. And I've been injecting now for 27 years. I took a lot of that without the help of good old Botox and my filler components.
Fantastic. And if you do want to listen to the episode, it was episode 176. So quite a long time ago, actually.
Nearly 100 episodes ago.
Yeah. And Felix, tell everyone about yourself. You're based in Singapore. We're going to be seeing each other in about a month's time in New Zealand. We're doing a masterclass together. I'm excited about that. But tell everyone about your practice.
Well, hi, Jake. Hi, David. Hi, Stefania. I'm Felix Lee. I'm from Singapore. I teach for Allergan Medical Institute, so I've gone around the world, had the chance to meet great people like you guys, have fantastic discussions, and mostly I inject fillers, botulinum toxin, mainly for lifting, to counter age, help my patients look younger, feel fresher, and I'll be in Australia on the 28th of October, and after that I'm going to New Zealand with Jake. It's going to be a really, really exciting event because I've been in a chat group with a bunch of IA patrons, so we've been having some discussions. But I actually think it's really interesting, the injectables environment, so to speak, in ANZ, and I just think it's going to be so much fun when we meet and discuss in person.
Yeah.
Fantastic. And if you want to hear Felix's episode that you did with us before, it was episode 224. And it was part of our Beauty of the World mini-series. And we spoke about Singaporean and Asian aesthetics. So that was really interesting one.
I think we should get Stefania in the chat groups. That'll be liven things up even more.
Yes. 100%. We'll have more fights. So maybe we'll start with Felix. You guys are actually both in China to launch this new indication for Botox. So just tell us about, your experience. I mean, generally in China, they do massive events, but I don't know how this one was launched. And I guess your initial feedback from the doctors that you were teaching, Felix.
I think in terms of the event itself, it was a meaningful event for China and I guess Asia as a whole, because it's probably the first time an approved indication for a major product coming out of Allergan, having launched its approved indication first in Asia. So it was something important for them. A lot of work went into making this happen. I think we're going to talk about the study that backed it up, and so it was just a meaningful event. The response from the audience is kind of interesting because I think everybody who's been in aesthetics has been injecting Botox in the masseters. So it's not something new or groundbreaking. But now that we have an approved indication, I think what's changed is that we now have the ability to study it. We now have the ability to have evidence-based practice when we inject the masseters. And I do think that's a big step in the industry as a whole.
Yeah. And Steph, you were there sort of virtually, as I understand it, because I knew that you were part of the launch. And then the next day we were in Jakarta together at a Profiler event. And I was like, how the hell have you just come from China? But turns out that you sort of tuned in virtually. So what was your part of the launch and what was your experience?
Yeah, I would have loved to have been in Shanghai with Felix. It would have been awesome. My part, well, as you know, Jake, I'm the ultrasound girl, and I kind of added the dimension of anatomy via ultrasound and did it through a number of different cases, but particularly focusing on Masseter and looking at the ultrasound appearance of the three bellies of Masseter, looking at Zygomaticus major, looking at Rhizorius and seeing where it is, looking at the different compartments within the Masseter and how to assess the masseter anatomically via ultrasound. That was pretty much my role. And plus I looked at the facial overfilled syndrome. I also looked at injecting hyaluronidase under ultrasound control. So I did a few little cases, but predominantly with an ultrasound slant.
Yeah. I've got a question here that I was scripted to ask, but I'm just going to ask something different. And you kind of alluded to it, Felix, in your sort of opening piece that you started off with. Masseter treatment is not new. It's been done ever since I've been in the industry, like 20 odd years. You're saying that it can be researched more now, but what would be the commercial impetus to encourage Allergan to do this? Because getting an indication is very expensive. It's time consuming. It's not easy. Why have they done this? Is it just for research, or is there a commercial aspect to this as well?
I don't know, I don't actually know the answer to that question. I think it's something that they've been doing for a really long time. It's not something that we just started doing. So I think it's probably come from a while back. But I feel that other than academically, I don't actually think the indication brings a great deal commercially to the company.
Right.
Am I right to say that?
Yeah. I mean, it's your opinion. I mean, I wonder whether having a study that proves a dose and an efficacy and a longevity and blah, blah, blah. I think that's nice to hang your hat on as an injector to say, you know what? I'm doing the technique because I can prove it because I've got a paper to back it up. Yeah. Whereas if you use another product off label, there's always that doubt that, well, is it 25 units or 40? I don't know. I'm just going to guess and see what happens. So it's nice to sort of have that data to back yourself up on. And, if we want to be medics and practice evidence-based medicine, that's kind of a nice thing to do.
Okay. Just thought I'd ask it. It was just my Jewish brain was going, well, how's this work? Why are you spending all this money? Okay, cool. So I'll ask the question I was originally going to ask Felix. So why don't we start off by clarifying and defining what is the masseter muscle? What's its usual function? Why is this a problem? Why are we treating it? Is this just a regional thing? Is this just let's unpack that.
No, I think that's actually a super question. That's how I started my talk in China.
Yeah.
So the masseter muscle, or the chewing muscle, right? It starts from the cheekbone and it inserts into the jawbone, and it helps us to close our mouths, to chew, to masticate, in a way, to talk and express as well. So it's just a really, really important muscle. But I was saying in the talk in China that just because there's an indication doesn't mean we have to all run to treat everyone's masseters. when we do a treatment, the goal is what the treatment does for the patient. So I'm actually going to bring up a separate study that I think is really, really interesting that they did in China. It's actually a questionnaire for 4,200 Chinese responders, asking them, what do you find attractive? So the premise is when we inject Botox in the masseters, we are going to reduce the bulk of the muscle. We're going to make it smaller. But what does that do for the patient? So interestingly, in that study, they use like pictures, like graphic representation, and they asked for a female person, do you rather she has a squarer, stronger jawline or a curved and smoother jawline? And it was 83% of them chose the smoother, more curved jawline. But for men, interestingly, we're split down 50-50. Because traditionally, Chinese people believe that if you have a really square jawline, it means that you're honest, you're sincere, you're a trustworthy guy like Jake, you know? And
how wrong they are. How wrong. Yeah.
But if you have like...
That's for lots.
Yeah. It's fake as well. Yeah.
Right. But if as a guy, you have a curve on your jawline, then you tend to be, you know, cleverer, sly. And those were traits that were traditionally not popular in Chinese people. But now, you know, the modern female, I think they rather their guy, you know, like a smart guy rather than a honest guy. You know, so it's kind of split down the middle now for men. But interestingly, that same study showed a series of different face shapes. And they said, so what is your most attractive face shape? And the first two, the oval face and the heart-shaped face, both have very, very curved angle of the jaw. Whereas the bottom few, the pear-shaped face, the square-shaped face, all comes with very square jawlines. So the point I'm making here is if you are trying to make the angle of the jaw more curved so the patient looks more feminine and more attractive in the traditional sense, for Chinese at least, then the masseter injection is meant to reduce the bulk of the masseter to achieve that sort of like aesthetic goal. But if you're trying to make the patient's face more oval, less square, and less rectangular, then the masseter injection is a part of this sort of combination therapy that you do with fillers, with energy-based devices to achieve that ideal face shape for the patient. And obviously, in my practice, there's another large group of patients who do Botox for the jaw, would be patients with teeth clenching problems that affects them with sleep, with headaches. But that, I need to clarify, is not part of what the Botox got approved for. So that bit is still off label, but it is something that can really improve the patient's quality of life.
Yeah, that's a really good point. So the fourth indication, at least here in China, is MMP, Masseter Muscle Prominence. So that's got nothing to do with the pathophysiology of clenching because of grinding or headaches or bruxism. That would be, seen as off-label still if the patient also had those symptoms. So just to clarify, if your patients are already clenching and grinding, that's not really part of this topic. So Steph, good point. What does on-label mean? Because we're talking about on-label and off-label. What does it actually mean? And I guess why is it important? And do you talk about it in your consent forms with your patients? Do you talk about on and off-label?
Supposed to. I mean, as I said, I've been injecting masseters now for the last 23 years. I was taught by Waffles Wu at a conference back in Bali. And we all started doing it back then. On label, what does it mean? It's kind of a drug that's been used for the same indication. And in this case, you're on a botulinum toxin or Botox in China, and hopefully soon in Australia will be on label. And I understand it will be soon. But it's basically on-label is a drug that's been used for the same indication, a dose. The route of administration is the same. You're looking at the same population group and drug formulation with no deviation from the approved TGA label. So that's the definition. I looked it up for you rather than making it up because I'm very good at making things up. So we don't have it in Australia yet, but I was just going to say something. I just thought I'd throw this in because it's not on the list of questions that was given. And it's interesting that China got the approval first because everybody seems to think that Masseter Muscle Prominence is something that is unique to Asians. And some of my Asian plastic surgeon colleagues here in Australia look at me and say, well, you wouldn't know what to do. And I go, well, actually, a lot of Caucasians suffer from Masseter Muscle Prominence. And I treat a lot of Caucasians and predominantly Caucasians with this. And I think you're going to get into it later, how to bring up the discussion, because many times people don't realize that they've got a bulky lower third. So it isn't specific to you guys, but yes, there are ethnic variabilities, but you get all the attention. But Felix, we've got to turn it a little bit onto us Caucasians.
I mean, back to David's point about, why bother? I mean, I do think obviously China is an absolutely huge market. And if this becomes, approved and ratified and signed and sealed and delivered, I think that makes sense from a commercial perspective. I have no insights into, the marketing of it, but it would make sense to launch in a country where, like you said, Felix, many women worry about this and they would like to have a different shaped face rather than, of course, it's for all races, but I think Asians would very commonly say, I would like to be narrow in my lower face, where it's probably not as common with Caucasians. So, yeah.
You know what's the difficulty with Asian females as well? The Asian face is inherently short. We have short chins. So our chins are inherently recessive. So when you compare that to the ideal oval face, if your chin is already small and you have really big masseters, it makes it doubly bad. You see? So it is something that just bothers a lot of people around here when there's this pursuit of that perfect oval-shaped face, but yet inherently you're born with a small chin.
Again, another question that's just come to mind. I love to throw these curveballs. Jake's blood pressure goes up every time I do this. It's not white coat syndrome, it's Dave syndrome.
Yeah.
Do you think that this, Felix, I guess, desire for Asian patients to have less prominent masseters is as a direct influence of like Western culture? Because that's the way Asians were meant to look, right? That's the way your face naturally occurs. Is this wanting to almost appropriate Western culture the way that Caucasian faces look, or is this something that's inherently always been an issue irrespective of Western culture influence?
I think to be very, very honest, up to about maybe 10 years ago, the primary goal of Asians doing aesthetics is to look more Caucasian.
Yeah.
I think that is it may sound not great, but it's true. Why do we desire like higher noses, fuller lips, stronger chins? It is this Western kind of influence. I want to look like a Hollywood idol. But I would say that in the past 5 years or so, that's changed a fair bit in two directions. The first direction I feel is that the patients nowadays are just more keen to look like themselves, a more beautiful version of themselves. And what do they perceive as beautiful? Generally, it's tradition and media, right? So traditionally, if you look at like Chinese paintings, that kind of stuff, this oval-shaped face, this desire for oval-shaped face has been there for like 200 years. Everybody just wants to look like this, But in recent times, I think they want to look more like Korean idols, Chinese idols, more so than Western idols, you see. And I do feel that this desire for Westernification, as Waffles called it, why do we keep bringing him up today? It was definitely real up until about 10 years ago, and then people started changing a little bit, and their desire for beauty, I think, is more individual nowadays.
Yeah. Okay, so how does the Botox actually work to address MMP? So what's it doing to the muscle fibers? And we've also had some discussions around impact on the functionality of that area as well. We had a very interesting discussion with Professor Bob Kana. Mm-hmm. Must have felt like 200 episodes ago. And we talked about the complexity of that area and how treating this zone in a way that isn't correct can impact the functionality and the way we chew our food and the whole mastication process. So yeah, can you just talk to that a little bit?
I think the Botox relaxes muscles. We know that's what it does. But what is happening in the masseter is a little bit different from, say, the corrugator. Because when we inject a small, tiny muscle or facial expression, we are just reducing its function as a whole. Whereas in the masseter, we are relaxing a part of it. because the masseter is a huge muscle, but we're really relaxing the part of it that has an aesthetic impact, which is the area that is closer to the angle of the jaw. So when we reduce the strength of the muscle bulk then reduces over time, and that's how we get this sort of shrinking kind of effect. But does it affect the strength of chewing? I don't think it does. I think the rest of the masseter takes over that strength, so to speak. And you notice that when the patient, after a long period of treatment, when the patient clenches, you don't feel the masseter anymore near the angle, but the strength of the masseter higher up remains more or less the same. So I don't think it has a big impact on functionality or chewing. And that is also why I think it is one of the better, so to speak, areas to treat with Botox compared to, I'm going a bit off topic, but it's kind of interesting. You know, people do Botox for smaller calves, for flatter shoulders, this kind of stuff. I feel like you're exchanging an actual function of the muscle for an aesthetic outcome. But with the masseter, you are merely just moving that function slightly away from the angle of the jaw.
Yeah. Did you have anything to add to that, Steph? Do you disagree? We can have another debate if you want.
You know that I'm the one that usually has touching things on. It's interesting. I predominantly agree with what Felix has said. And I think if we think about it, there are 4 muscles of mastication. So you've got the masseters, you've got temporalis, and on the other side, on the inside of the ramus of the mandible, you've got the medial and lateral pterygoids. I think you probably do get a little bit of muscle fatigue when you're injecting the masseters. Some patients report that if they're chewing on steaks or squid, they might report a little bit of that. I think one of the things that I've learned over the years, I mean, it's not impacting them 100%, but they might report it. One of the things that I do after prolonged treatments of the masseter is I always keep an eye on temporalis and see whether temporalis is actually gaining greater strength and becomes a little bit more hypertrophied over time if we really nuke the masseter. Do I see it often? The answer is no. Do I do a lot of masseters? The answer is yes. Recently, Hee-Ji Kim has published a paper, and he is the master of anatomy, showcasing how if we're injecting the lower third of the masseter, where we've got the greatest number of neuromuscular units, where we're actually trying to get the greatest impact cosmetically, but also from a functional perspective, that sometimes you can actually get the portion of the masseter where it originates from becoming a little bit more bulky. And it was only after I read that paper that I actually saw it in one of my patients. And then I went to target that part of the masseter as well. But I've done it in one case. So, maybe a little bit of muscle fatigue might be originally experienced. And that might be dose related as well.
See, this is where I think it gets interesting, because even though we have clearly defined the on-label use of Botox for masseter is prominence, not clenching, grinding, etc., there has to be a functional impact on those other muscles, because they work like a pulley system. One muscle does one thing, temporalis does another, and you've got your pterygoids on the inside. So if you weaken the stabilizer on the outside, there has to be an impact. So I predict that there will be some patients who suddenly get some different type of bruxism symptoms that they never knew they had as a result of treating MMP, because the history wasn't taken in the first place, or they didn't tell their doctor, oh, by the way, I've got a clunky jaw every time I open my mouth. That history wasn't taken. So I think it's really important for injectors listening, try and be clear that it is the prominence only that you're treating. And if there are symptoms of bruxism, be cautious, or think about those other muscles, or refer to the dentist first. I think it's worth saying. Steph, you brought up something interesting. You treat a lot of Caucasians, and maybe those patients aren't coming in requesting something to be done with the shape of their lower face. Maybe they never saw it. I don't know. So how do you bring it up in your consults without offending particularly women? Is it something that you show in photos and sort of see what they think before you bring it up, or how do you do it?
Well, I think, Jake, you know that I'm a single striker and I say what I think and I don't have a filter. I actually think it's all about your original consultation with the patient and establishing a rapport and a relationship with them. So I always start with taking a medical history. And on the bruxism thing, which is not part of the MMP, when I'm actually doing Masseter MMP, I always tell them to see their dentist as well and, do a multidisciplinary approach with the patients in the ones that are needed. How do I bring it up? Well, I usually ask the patient, what brings you in? Tell me your top 3 areas of concern with number 1, 2, and 3. And it's like, hello? Like, seriously, you're actually hitting me from over here with your Masseters and you haven't brought it up. So I kind of give them some airspace the way that you've just given it to me. And then I listen to them and pretend to listen. And then I go, okay, now you've told me what you see. This is what I see. And in some cases where I actually see the Masseters before I see anything else. So I pull it back and I say, listen, as an injector, this is how we look at the face. I've not met you before, but the first thing I look at is overall facial shape. And you have got a very square jawline. Have you ever seen that? Yeah, I have seen that. And I ask him, do you actually clench? Do you grind? Do you think that you do anything like that? No. And then some of them say, how did you know? And I go, because I'm in your bedroom at night and I can actually see you doing it. So I kind of diffuse it a little bit with them just to actually bring the topic up without offending them. Photography, I find, is just a great way to bring it up because I look at the bizygomatic and the bigonial distance and just talk about, beauty and what we consider beautiful for a female versus a male. Not that I'm trying to put everybody in the same bucket, but somebody with really strong Masseters, I usually bring it up in the consultation. Some pick it, but the majority of Caucasian women do not. So they're a little bit surprised or they're a little bit, they kind of try and work out how is it that I picked that they actually got that habit. So I bring it up.
Yeah, and I'm guessing if I ask the same question to you, Felix, your patients are probably begging you for it before you've even said anything. So it's the other way around because they have an understanding that it can be treated.
Yep. I get it around both ways. Patients come in asking for it, whether they need it or not. Because I think a problem with MMP treatments in Asia as a whole is that if you directly translate the Chinese name, not the sort of like professional name, but what everyone calls it on the street, 瘦脸针, it translates directly to slim face injection.
Right.
And not masseter reduction or angle of the jaw reduction. So I have a ton of requests for slim face injections, and then I got to tell them, no, your face isn't looking bulky because of that, and so on. And we get the referral from dentists actually saying, because we don't get dentists doing Botox in Singapore, not many of them at least. So the patient comes in, referred from the dentist saying, oh, I broke my retainers, that kind of stuff, and then we work with the masseters.
Right. All right, Steph, question for you. Are toxin or Botox the only way to treat this condition? Are there surgical options as well, or is this pretty much the only way to go?
Yeah, great question. I think number one, you've got to take a history, like Jake said before, really understand what's going on. And when you've seen it and the patient hasn't brought it up, you need to dig in a little bit further. Then as a clinician, I think we need to assess, once we've got the history, we've asked enough questions, what's actually causing it? Is it actually MMP? Is it the masseter? Is there parotid enlargement? Is there too much subcutaneous fat in that area and you're barking up the wrong tree? Or is there a problem with a bony prominence with the mandible? That's the issue. So you've got to actually, unpack, as you would say, David.
Yeah.
What is the issue? Because if you don't have the diagnosis correct, you're wasting your time. So if it is MMP, is Botox the only solution? And the answer is no. Prior to Botox, if the problem was with flaring of the mandible, it was surgical debulking of either the masseter plus removing part of the bone. And that, as you can imagine, is fraught with a little bit of danger because you've got some pretty important nerves in that area. The facial nerve just happens to be in that locality. But, it's a pretty big operation to create this facial slimming. So when Botox came into the picture, it's kind of led to a paradigm shift. As I've been reading through the papers, I think there's also some evidence that radio frequency into the muscle, the masseter muscle, might lead to some debulking. I've never heard of that in Australia, but it has been published. So prior to Botox, the treatment, which I understand was something that came from the our Asian fraternity, is that it was surgical. But that's been largely replaced, I think, Felix, you tell me, by actually, if it is MMP, if that is the diagnosis, it's Botox is your go-to.
Yeah, no, I 100% agree. I think a mandibulectomy is notoriously dangerous. That's one. And two is, I think a lot of times in order to achieve that perfect overface, these Chinese girls have done everything. So there was a wave of mandibulectomies. But the problem is you realize that as we are using other treatments, fillers or that to support the angle of the jaw in order to support the jowls, these girls who look fantastic after surgery in their 20s, they start to realize that they're losing a lot of support as they get older because there's nothing that's going to support the jowls more than bone. And so I think more and more we are moving towards Botox. I think the answer kind of to that question is there are many ways to make the angle of the jaws more curved, to make the face smaller. But to make the masseter muscle smaller, I find Botox is more or less the only way, or at least the only practical way.
Yeah. Now, Steph, I gather 2 years ago in Australia, you sort of spoke about some of the study behind, the dosing and how they came across this technique. So just give us a very high level sort of summary of that study, and then we can sort of talk about the technique.
Sure. So what I presented at NSS is basically whenever they're publishing any data, they're looking at measuring safety and efficaciousness of the product. And the main parameters that they were looking at is different doses, and they were comparing 24 units per masseter, 36 units per masseter. They went up to 96 units in total between the two. And they basically found that irrespective of the dose, the safety profile remained the same, but the higher the dose, the longer the duration of effect.
Right. And so, I mean, I think we alluded to this right at the start, but I understand that this study, the early study started way over 10 years ago, I think about 2014 or 13. I know that Stephen Liu was involved in some ways, some of those sort of earlier studies. So, these things go through different phases, different trials, lots of money. So when we were asking that question about, well, why is it on label now? It doesn't seem to make sense. Well, because it takes 10 years to sort of come to market. So I think it's important to understand that. So I gather that the dose that's suggested, and you guys presented the data in China, was 36 per masseter. So how does that compare to what you were currently doing in your clinics or doing prior to the launch in China? What were you doing in your own clinics? We'll start with Felix. Yeah,
so it was interesting. I told them that when you present before after photos, you want to present truth, right? So I never did 72 because no one told me to do 72. Now that I know 72 is evidence-based, I'll do it, But what I did know all those years ago was that I needed a consistent starting point. Because if I did more for patient A, less for patient B, even more for patient C, I'm never going to know what works, how do I increase, how do I decrease. So I just arbitrarily came to this point of 64, 32 on each side. And I started that for the majority of my patients. And I find that when I have a consistent starting point, I can kind of adjust it in a way that is not evidence-based, but at least it's like kind of systematic. So I've been doing 64 to 32 on each side, 3 divided injections for as long as my career. I think, so once again, I think this is not really part of the study we presented, but my own personal experience, I don't know if I can share that here. I find the most effective way to do Botox with MMP, it's not so much the dose, but the regularity at which we do it.
Okay.
So what I mean by that is we use, if you think about Botox to say the frown or the crow's feet, we frequently tell our patients it's going to last 4 to 6 months, right? At the 4 or 6 month mark, the results are more or less gone. But if you keep the masseter with a big enough dose, even at 6 months, 8 months, it's still a little smaller than before. And we kind of explained it before because this is a muscle that exercises all the time. So if you didn't allow it to do so, you are actually kind of taking away its ability kind of to exercise itself back to its original science. And so this is what we kind of came up with. The example I like to give is, if you don't go to the gym for a long time and you get back to the gym, you can't actually lift the weights that you could lift before. It's going to take weeks or months of work lifting lighter weights, and then you recover that strength. And when you recover that strength, look in the mirror, you also recover the bulk of that muscle. So I find the most effective way to make the treatment last is to actually do the treatment every 4 months, very, very regularly. So I might start with 64 for my patient. She comes back at 4 months' time, and the MMP feels smaller, so to speak. I might reduce it to 48, to 40, and eventually there are a lot of patients. So I presented a 6 separate case series. These are patients injected for more than 8 years, and currently they see me every 4 months, but we're injecting a really tiny dose of 16 on each side, and it gives them the same results as when they were injecting 64. And I think this is more of a functional thing, because we're not reducing the entire muscle, so the muscle uses another part of it to perform its function.
Yeah, interesting. What dose were you doing, Steph? Sort of, do you have a set one, or do you vary it depending on the size?
I'm not Singaporean. I'm not as structured as what Felix is, but I'm listening to you with great intent, and I actually like the way that you're thinking. It's very scientific. I think I'm a little bit more artistic, like the picture behind me. I think one of the things, assessment is the key, really. And I think Masseters are more forgiving when you've got a young patient, say between 20 and 40. I think when you've got an older demographic, there are several other factors that we need to take into consideration. And again, we're going to look at the difference in ethnicity here, because I'm going to be comparing predominantly Caucasians versus your Asian cohort. Your skin is thicker, you're more supple, whereas we fall apart at the drop of a hat, Felix. So Caucasians tread with caution. I think for me, the dose, what I find, and this is again on my personal experience, anecdotally, I've treated a lot of patients long-term, and I should actually go back and re-look at them now. But again, this is gut feeling without pulling out the data, because what we actually think we're doing changes when you actually take the data out and really analyze all the sheets of Botox that you've actually done. Typically, if I'm doing MMP, my doses are higher in a younger cohort that hasn't got any jowls, that is younger, because I do not drop them aesthetically. So I always talk about medical versus aesthetics in terms of my outcome, in terms of the consultation. So the younger patients, I tend to hit them a little bit harder. Again, it depends on how big it is and what the rest of the face looks like. The older group, and I'm going to go 40 and above, because I think the skin just does not recoil as well the older we get, and we start getting jowls, because the aging process is a disaster and it happens to all of us. So what I don't want to do is accelerate and make the jowls worse, because like you said, not only does a bone hold up the skin and the structures, but the masseters have got like a pulley system, and they're kind of like a tent pole that holds the skin back as well. So traditionally for me, my dose ranges in a Caucasian, in a good Caucasian that is structurally intact and young with no jowls, happy to go to 20, 30 units per side. Have I gone stronger? The answer is yes. But again, the average 20, 30 units. Somebody that is 40 plus, and I'm concerned about making the jowls worse, unless I want to stick some deoxycholic acid. Very good for business. You deflate the masseters, get a jowl, and bang, out comes the Belcara. The older patient, I drop my dose. But anecdotally, what I find, because there are a lot of patients that I've actually been treating and that I see regularly with Masseter Muscle Prominence, the dose tends to decrease and the intervals tend to increase over years of continued injection. I tend to agree with you that the same way as even for corrugators and other areas of the face, you don't want atrophy of the muscle. You actually want that muscle activity to actually come back a little bit. But to me, the deciding factor with my dose is the overall facial aesthetic and how much I actually want to slim the lower third of the face, based on the proportions of the upper and middle third.
Yeah, it's really interesting because, I mean, David, you've sort of trained, well, not trained, but had hundreds of injectors under you in your different clinics. And I reckon if you asked 100 injectors, what's your standard dose for a masseter to slim it? It wouldn't be as high as 36 per side. I reckon most people would do 20, 25, maybe maximum.
Yeah.
I have to be honest, if someone's got a decent masseter, I tend to start with 40-40. That's just sort of my routine. But of course, they might be bruxers as well. So there's a functional impact as well. But it's kind of, for me, reassuring that the tested and tried dose is closer to what I was doing than what many people would, I guess, anecdotally doing. Because we know that dose is equal to longevity as well. It's not just slimming it, it's also making it last. Because this isn't a cheap treatment, so you want it to last as long as possible as well.
Yeah. I mean, I had a lot of issues with injectors over the years, and I think with this particular treatment, I think a lot of the time they're actually missing the muscle.
Oh, right, okay.
Because where are they going to get training? They can't get trained by one of the reps, so they're watching YouTube or whatever.
That's a very good point.
So, I mean, that's been the problem. I'd have a lot of people that need to come back in for subsequent treatments, or they complain it wasn't lasting as long as what they thought it would. And I think it was injector error because there wasn't any training for it. Although it was a popular procedure that was being requested and done,
yeah,
I don't think everyone was doing it correctly.
Such a good point. So going back to on-label, we can now be taught as a technique, a dose, a method, boundaries, borders, risk areas, etc. So that'll be exciting when it comes to Australia. So what is the actual technique recommended by, the new protocol? Maybe we'll start with Felix, because you were there sort of either delivering the teaching or at the event. What were they actually suggesting? How many points? What's the depth? What's the needle? Blah, blah, blah.
So 3 points, 12 units per point, sharp needle, deep onto the bone. So that is very close to, I think, what most of us have been doing.
Well, you say that, but you see a lot of injectors using a little insulin BD needle, and yet you've suggested you want to get down onto the bone. So again, I think a lot of injectors are skirting around maybe even the subcutaneous tissue, let alone in the superficial muscle belly, and just missing the muscle.
Well, if they're injecting glabella frontalis crow's feet, they're relatively superficial injections compared to this. So I think it's not difficult to understand why we've had so much inconsistency with the outcomes.
Yeah. So is there a suggested needle size and dilution of the Botox as well?
No, I don't think so.
Interesting.
I use a 30G needle just for comfort, but I think it would do the same much. This actually, can I extend on David's point, because I think it's a really good point. I think that complications with Botox MMP, there's a large part of it where people aren't hitting the masseter at all. And I feel like this may sound really silly, but I feel like in Asia, especially because of that slim face injection mistranslation, there are a lot of people who are directly injecting the jowls with Botox.
Right.
Because they're like, this injection reduces what it hits, right? So there's weight here, let's inject right here, and that's where you get rhizorius on both sides. I always say, if you have a crooked smile on one side, you maybe got it wrong. If you have a paralyzed smile on both sides, you were definitely not intending.
Yeah, if you look like you've had a stroke, something's gone wrong. Yeah,
well, it's a double stroke.
Yeah.
Steph, you're the ultrasound guru. We'll come on to sort of your ultrasound findings in a sec, but what's your thought on depth and needle? Because, most injectors aren't changing to a longer needle. So what's your thoughts on what we were just talking about?
I'm really glad, Jake, that you brought that one up. I really am, because I don't know about you. I've actually had I do a lot of off-label injections with Botox, every part of the face and parts of the body, but predominantly the face. But I think you learn the most when you actually have a complication. So there was a time, and it went back 15 years ago for me, when I had my first paradoxical doubling up of masseters and couldn't work out what was going on, and it was bilateral. And I remember, ringing up all my mates, and so I rang up Stephen Lucas. He had published on this, and it said, in the paper, it said, if you get a paradoxical bulge, it's because you've got a hematoma. So I rang him up and I go, Steve, I don't know what's going on here. This has happened within 24 hours of the injection. And he goes, oh, it's you've got a hematoma, just sit on it. And I'm going, listen, I'm good, but I'm really not that good to get a hematoma on both sides. And the masseter is in such a tight compartment. How could I have possibly done it? And I think from complications, you learn everything. So out of all the areas of the face that I inject, I've had every single complication now with Botox in injecting, except for striking rhizoria. So I still have not hit right. It's the only complication I haven't had. In terms of the masseter, I think that the needle length is supremely important because then at Greg's rooms, we had a run, him and I, of a number of paradoxical masseter doubling up, and we're trying to work out what was going on. And one of the first things that we worked out, like Felix has said, is that if you're using a BD, that's, some of these BDs are 4 millimeters, some are 6. Sometimes you're not even getting through the subcutaneous fat and you're not actually getting to the masseter at all. Very worried, Felix, that you're telling me that people are injecting the Jowls. What is going on in Asia? Like, seriously, that is bad anatomy, but you can pull that out of this presentation. But that's concerning. I think once I got the complication and I finally worked it out because I brought ultrasound into it, and that was 15 years ago, and that was that masseter that has then traveled around the world, that ultrasound image. What I learned is that a short BD is incorrect. So I now inject, I think, a 30 gauge needle that's 12 or 30 millimeters, perfect, especially if you're going to go deep. I actually now inject with a 25 gauge 30 millimeter needle. Now, which is a little bit over the top, but I'm Italian, so I can do that. There are some people that have got huge masseters. And in some cases, if I'm not using ultrasound and I put that 30 millimeter, 3 centimeter needle, sometimes it's halfway in somebody with really a prominent masseter muscle. So I think a long needle, definitely minimum 30 gauge. So I reckon that should be discussed. The length of the needle is very important. Minimum 12 to 13 millimeters, the longer the better, so that you can get into the deeper valleys of the mass.
You can't bring a knife to a gunfight, Steph.
Me?
Yeah.
Hey, all is spade. I'm sorry, David.
It's an interesting point because normally when something is on label, there's a defined needle and gauge and the whole technique is sort of defined. So I'm amazed that they haven't sort of specified which length needle as well should be used because the technique will say go deep or touch the bone or whatever the technique actually says. So I think that's important. So even though the on label might say don't change the needle, I would strongly question that and do what Steph said and go deep.
Okay. Won't say anything inappropriate. Steph, can you explain what paradoxical bulging is? Why is it happening? And how do you treat it if it happens?
Thank you for asking the question, David, because for the audience, I'm just in the process with Frank Lim and Mark Magnuson. We've just submitted a paper on this actual topic because we're trying to understand it, and it's with ultrasound evidence to showcase 6 studies, 6 cases with ultrasound on why we actually believe it's actually happening. So there's, again, going back to Hee-Ji Kim, the anatomy guru, he published a paper on the DIT, which is the deep inferior tendon. Because when we're looking at the masseter, it is a very complex structure innervated by the trigeminal nerve, and it's all compartmentalized into these neuromuscular units. And when you have a look at the masseter on ultrasound, you can see these multiple septae that divide the masseter into all these muscle fascicles. So according to Hee-Ji Kim, he believes that the paradoxical movement is basically, the definition is basically that when you're injecting the masseter, that within a 2-week period, instead of seeing that the masseter is shrinking in size, because you start seeing the facial slimming anywhere between 2 to 4 weeks post-injection, and the maximum slimming is happening at 3 months, the paradoxical masseter bulging tends to occur within 2 weeks. I've actually seen it within 24 hours with when the patient clenches and they're chewing, they get the Popeye symptom where you get this kind of prolapse of the muscle coming out every time that they're actually clenching. What is the mechanism? Up until now, the published data on this from Hee-Ji Kim stated that it's this deep inferior tendon. So what I want you to imagine, and this is the way I describe masseters when I can talk about it when I'm not talking for Allergan, is that it's basically got 3 bellies. So, and if we look at the origin, which is at the zygomatic arch, and the insertion is at the ramus of the mandible, we've got a deep tendon, we've got an intermediate, and we've got a superficial layer. So 3 bellies to the masseter, and they basically come to the angle of the mandible. And when somebody clenches, you get that masseter, the bulging or the prominence that we're trying to address. Why do we get the paradoxical doubling up? According to Hee-Ji Kim, what he thinks is happening is that on the deep surface of the superficial head of the masseter, there is a deep tendon. There's a tendinous structure. And what he believes is happening is that when you're injecting into the deep and intermediate head of the masseter, which is if I do this like that, and then we've got intermediate, superficial, and deep head of masseter. And if you're doing 2 injections, and we'll go back to the injection points, but look at the literature, it's anywhere between 2 to 3 injection points to 6 or 5. But traditionally, like Felix has said, it's now been described as 3. What Hee-Ji Kim says is that if you do 2 deep injections, or 3, that it's this deep tendon that stops the diffusion of the Botox to the superficial head. And it's basically bulging after the injections. We're actually going to partly disagree with this with our paper. We do see the deep DIT on ultrasound quite clearly. What we've actually observed with ultrasound, and this is in a short case series, is that masseter, the 3 bellies of masseters are either going to work in balance when they contract. All 3 bellies contract synchronously or in balance, or before you even inject the patient might have a more anteriorly based or posteriorly based muscle belly. And if you observe that before you inject, it's kind of very important because they might have a bigger muscle belly with their deep or intermediate or superficial tendon. And you really can't see this when you're actually looking unless you've got ultrasound. What we think is actually happening with the paradoxical doubling up of the masseters is that there's an uneven distribution of the toxin, and a bigger belly of this compartment hasn't received enough toxin, and hence it gets more power because it hasn't been nuked. So it will then, and it's either in our cases, in our 6 cases, it was predominantly the deep or intermediate head. And one of my cases happened to be the DIT that led to the superficial head being what you could palpate. So what we found is that the paradoxical doubling occurred because of all the facial septae, the division of the 3 muscle bellies and all these fascicles, and with the toxin not being distributed to each of the muscle bellies. And the bigger muscle belly that couldn't be seen visually, but we could see it with ultrasound, didn't get a high enough dose, therefore had more power. And when the patient clenched, led to this paradoxical doubling up. And so to fix that, under ultrasound, you identify that muscle belly and specifically target it with more toxin if the problem hasn't resolved after 2 weeks. And that led to a no further bulging of the masseter.
You got it?
Was that too much? Sorry.
It was very, very good. So what are the potential side effects? We've sort of touched on maybe weaker. That's kind of obvious, but what should we be telling our patients in their consultation? Because if we don't tell them, they get worried, right? They call us saying, oh my God, I'm eating steak and I feel like I've lost power in my face. But then we also spoke about, risorius. So how are we going to avoid risorius without an ultrasound? Because, not everyone is as good as you, Steph. So back to Felix, how are you going to avoid risorius and what are you going to tell your patients?
Yeah. So one thing that Stefania said that I really, really loved is, we all have complications, but hitting the resource is not one of them because it's so easy not to. It takes 1 second to get the patient to bite, feel the anterior border of the masseter, and inject behind it. That's it. That's it. With that, you avoid resource, you avoid zygomatic muscles, you avoid all the smiling muscles actually. So once again, get the patient to bite, palpate the anterior border of the masseter, and inject posterior to it. So that is all there is to it. I think in terms of downtime and risk, with any injections, we counsel for downtime of pain, bruising, but I find that to be very rare. Despite the masseter being a very vascular muscle, I still find it to be very rare. In terms of risk, I think the other than an actual complication like hitting a muscle that you did not mean to target, right, which you can avoid by palpating and marking out the masseter. The two things that we're most worried about is this paradoxical bulging, and number two would be an aesthetic kind of undesirable aesthetic outcome where you feel this hollow beneath in the subzygomatic space. So in terms of bulging, I actually wanted to take this chance to say, hey, Stefania, let's do a study. So I'm kind of heartbroken that you've gone down that path already, but I'll text you later. I have an idea, I think to make this like really short for everyone, paradoxical bulging, we think that the three hits are not evenly paralyzed. And so the hit that wasn't paralyzed is bulging through the hit that was paralyzed. So we think this is a deep and superficial problem, right? So how do we traditionally treat that? We put a really long needle down to the bone, inject, and we pull out and inject. So we try to affect all the three hits as we inject. Obviously, this is done without imaging. So we used to think this was a superficial and deep problem, right? So one of the layers is bulging out through the other. But I'm thinking, and if you're listening, you're hearing this on IA first. I think it might be a left and right problem. It, as you mentioned, it might be uneven weakening of the masseter, so that the stronger bits are bulging through the weaker bits. And I just think that an ultrasound study would be brilliant to show something like this. And yeah, I'll catch you offline. Catch Jake offline, see if we could do something together. I think that's interesting. But anyway, the solution to paradoxical bulging would either be traditionally put a needle down to the bone. If your needle's not long enough, you're going to get this for sure. Down to the bone, pull it out, try to affect all three hits. But now, if you think that this might be a left and right problem, and without an ultrasound, you can observe sort of like the movement of the masseter when the patient clenches that movement, you might actually get away with injecting around the bulge rather than deep into the bulge. And that's something that's really, really interesting. And I don't think anyone's talked about it before. So I can actually honestly say you heard it first on IA. But yeah, it's something that we need to study. The other thing about the subzygomatic hollow, it's that one is a very Asian thing. I'm not sure. Just for the sake of interest, there are kind of like a East and West aesthetic difference whereby everybody wants to be lifted, everybody wants to be tight. But I think Caucasians tend to want a more defined look, right? So you have a defined zygoma, you have a defined jawline. Whereas in Chinese, there's this word called yu tai, which means young looking. That simply means fu. So everything has to be kind of like stuck together, right? So when you have jowls, when you have big masseters, actually the whole bulk makes your face look full. And so when you lift the face or when you reduce the masseter, they get a better face shape, but they're seeing the subzygomatic hollow now, in contrast with the cheek and jawbones, and they're like, well, that's not desirable. I mean, if the patient has that need, just a small bit of volumization in the subzygomatic space, and that's all.
I think that's a really important difference between Asians and Caucasians. You guys like the fuller face. Having a subzygomatic hollow is hugely desirable for us.
Yes.
So if we can get that by injecting Botox into the masseters, that's great. I think this is where, from my understanding from speaking to Asian colleagues, you guys have pulled back a little bit from your doses, which were much higher in the past, with the concern that you got this subzygomatic hollows, which is not a desirable aesthetic outcome. Is that true?
Yeah, people tell me the same thing as they tell you, but I just don't feel that, because where the patient sees the hollow is in the, I'm sorry to say, I can't describe subzygomatic hollow better than saying, where do you see the hollow, in CK4 or in CK5? Right? Why am I saying this is because if the patient wants to be fuller, they tend to want to be fuller in the CK5 area, which is anterior to the anterior border of the masseter, right? And this, well, I don't like to feel in that area. I think it makes the whole face lose its definition and its structure. But at the same time, I don't think a masseter injection can affect an area where the masseter is not.
Yeah, fair. Just for the people who don't use MD code, CK5 is like the buccal area.
Just on rhizoris, because I think it's very important, because it has been struck and it can lead to complications, and it's not something that you want to do. If you've got somebody with a Cameron Diaz smile and you get a bilateral rhizoris, that's your signature smile. You're just going to have to handhold, because there's no way of getting out of it. I think if we think of the origin and insertion of rhizoris, which is very superficial, and it can come from the parotid, the fascia over the masseter, from the zygomatic arch, it can come from any of these areas, and then it comes across and it inserts into the modiolus, because that's, and it can be high, medium, or low, because it depends. You don't know. It's in one of those spots. But the key point, it is superficial. And I think one of your key points here is that when you're delineating your masseter in terms of pre-injection, the anterior and posterior border are super important. From the oral commissure to the tragus, and staying at least a finger breadth below that, and marking the mandible, but staying 1 centimeter posterior to the anterior border of the masseter is important. And I would actually think that injecting as you're coming out is not a good thing, because if you're doing that as you're coming out on exit and you happen to have a rhizoris in that area, especially in the more anteriorly placed masseter, you could potentially strike rhizoris, and that could actually lead to an alteration of the smile.
Yeah, it's a good point. You're sort of saying slightly paradoxical things, because if you don't hit the 3 heads, you're going to get paradoxical bulging. Yes. And if you stay deep, then fine, you're safe, but then you don't get the head. So it's sort of like you almost want to do a pullback, but midway, but not all the way out of the muscle, and hope that you don't get that paradoxical bulging. Or just do it under ultrasound and just target all 3 heads sort of individually. That's the other way of doing it, but most people don't have ultrasound.
But if you don't have ultrasound, because I've compared the two, marking the masseter and just getting the anterior, posterior border with the patient in full clenching, oral commissure to tragus, 1 centimeter below that line, mandible, and you palpate and look at the 2 sides. Is one side bigger than the other? Because sometimes it might be like that. If you place your finger on the point of maximum protrusion, that tends to correspond to the superficial head of the masseter. And then if you then do 2 other points that are lower and a little bit more anterior and posterior to that point of maximum protrusion, and the 2 lower points of that pyramid or triangle are deep, but the point of maximum protrusion, you don't go as deep, you will actually get all 3 heads. And I would think that injecting as you're coming out is not a good idea.
Yeah, that's a really good point, Steph. So back on the on-label technique, how far apart are these 3 points? And is there like a particular location for them, Felix?
Yeah, so what was thought is it's the 3 points of maximum protrusion, as Stefania has pointed out. But I will say that I do it a little bit differently. I think it's very, very similar, but I've always had this theory that if I'm trying to reduce the masseter in a specific part of it, then why don't I go all out and do that? So my first point is always the lowest and most lateral point where I can feel the bulge. Mm-hmm. So you notice how Stefania's first point is where the bulge is the greatest.
Yeah.
But I feel like my first point is where the bulge is the greatest, where it is the lowest and the most lateral. And then I go 1 centimeter up and look for the area where it's bulging the most, and 1 centimeter in and look for the area where it's bulging the most. So in the end, whether we're talking about what I'm used to doing, Stefania is doing, or what was taught in China, the point here is that it's a really big muscle, and you are weakening a part of it. So you want to weaken a part of it that is strong. And so you can't just look at it, you have to palpate it, feel it. And in fact, I actually think there is a direction where the masseter bulges. And if you go directly with that direction, if your direction of injection is opposite to the direction of the bulge, it kind of gives better results, maybe. But the point here is just that you have to feel it and inject it where it's strong.
Okay, so just for the listeners who maybe are sort of driving their car and can't think about this or see you guys, so if you bite down and you've got a bulge, you're basically sort of drawing 3 dots of a triangle on the edges of that bulge around 1 to 2 centimeters apart. Is that a good sort of
summary?
I think I'm dying on this podcast.
Summary?
Yes, I think I'm getting sick from you. You're not well, are you? I can tell.
Not 100%.
Yeah. Fine. So I guess just to sort of wrap this up then. So the other big thing that Steph mentioned was how are we going to make women not saggy? So how are we going to predict those people? So do you have any sort of, easy ways of sort of assessing the skin, Steph, to avoid that sort of laxity or predominance to jowling after masseter reduction?
Yeah, I guess the first thing that I do is I look at the age and I look for the jowl. And if it's there, then I proceed with caution. I do tell, and I do this in my discussion with the patient. I'll say, listen, the masseters are holding your skin up. I mean, clearly you're going to feel and see whether there's any laxity. But I usually say, I've got to be a bit cautious because we're all getting older. And if I debulk you too much, then what will happen is as the masseter deflates, then your jowls can get worse. That's all you've got to say. And that will either make them not do it at all, or I just drop my dose significantly and then I build it up. And they're the ones that I do bring it up with are the more mature patients where I can already see a jowl. And I think it's an important discussion to actually have.
Yeah. And do you have any other, clinical ways of assessing whether someone has a big parotid versus a big masseter without ultrasound? Is there any telltale signs or anything in the history that they should ask?
Yeah, I do. I mean, I think I learned again this from a case study as well, where I couldn't work it out. And I learned from a plastic surgeon in India that called it out. I think there's a beautiful paper again. Sorry about this, but we're in Singapore, Felix, but Waffles Wu has published on this. And it is the parotid gland. I think what you've got to look for clinically is that if you can see a diffuse enlargement that obscures the angle of the mandible and covers it, and it's in that retroramal area that will actually go over the corner of the angle of the mandible, and it's this diffuse swelling tends to be bilateral. I think if you've got unilateral parotid enlargement, full investigation because that becomes a medical case. But there are some cultures, like, for example, in India, because of their, spicy foods, you see this quite frequently that when you palpate, and again, I think Felix said it beautifully, key thing here is history and examination. Put your fingers on the patient. Ask them to clench. Is it masseter or can you feel a bulge? But the way that I assess for the parotid is get them to lift their head up and look for the bulge that you might see that it's obscuring the ramus of the mandible. And if that is there, I tend to target the parotid. I inject quite a few parotids, and I do it on direct vision to actually deflate it to improve the angle of the mandible.
Yeah, I had a great case, lovely patient, quite young, and she had been treated with masseters for ages and never really got a result. And she came to me and just went into her history, and it turns out that she had a past history of bulimia, so lots of vomiting. And when you have a lot of vomiting, your parotids can obviously grow because you're producing a lot of saliva. So anyway, long story cut short, we treated her parotids and suddenly she could see her jawline because, like you said, Steph, it sort of blunts the corner of the jawline, and a masseter never goes past the bone. So if you're seeing a bulky thing outside of the muscle or behind the ear, that's almost certainly a parotid. But like you said, if it's not bilateral or there's something funny or you feel a lump, you get them straight to an ENT surgeon or someone sensible to do a proper history and examination. I've got a question, or you're the business guy. Ask about how we cost this, because it can get expensive.
It can get expensive. Well, I was just curious, like, how do you guys price this? Do you sort of package it up? Do you do it per unit? How do you make this affordable for people? Because I know you said, Felix, you like to do it every 4 months. We'll start with you, and then we'll head over to our Italian friend.
We charge per unit,
right?
And you get a discount if you get 100 units at once. The purpose is not so much to give the discount. The purpose is because I want to treat this patient multiple times. And I feel that the best results is when you have the regular 4-month treatment. So you get a little bit of a discount if you get 100 units at one go. But actually, to be honest, I would tell you that if there is a patient who does several treatments with me, she will probably tell you that MMP Botox is one of the most worth it ones, at least cost to ratio, because after our initial doses, which are very high, we do keep the patient 64, 48 for maybe a year, because there's 3 treatments in a year. But once we start reducing, we can actually maintain that results with a very, very small injection. So to put things in perspective, if I'm doing, say, 12 units a side, 24 units multiplied by $15 is like $300. And that's an amount that is significantly lower than if you had come here for a facelift, non-surgical facelift, or an therapy. It's just a very it becomes very cheap to maintain if you do it regularly. That's what I'm trying to say.
Sure.
How do you do it down in Melbourne, Steph? Because here in Australia, we traditionally charge per unit. I know you're not a cheap injector. So again, how do you sort of make this affordable for your patients?
Yeah, I'm not a cheap injector. I'm pretty heavy-handed with my Botox, and I think I'm the generation that I started Botox way before filler. So I've got that confidence with my Botox and doing a lot of it in terms of dosing. So traditionally, I do full face, and I think when a patient understands masseter hypertrophy and parotid enlargement, and they see the results, they're bought into it. So I will always get my patients back in for their photos at 2 weeks for their traditional tox. But when it comes to the masseter and the parotid, I don't know what dose to use every single time. So I will get them back at 4 weeks and have a look at it, and they see it. And then they look at their photos, and they actually then come back and say, I need my masseters done again, or I think that bulge is now back, so I need it again. So I tend to strike heavy hard. I tend to decrease the cost when it's parotid and masseter, because sometimes for a parotid, I can go to 40 or 50 units per side. Masseters, I traditionally, depends on how big it is, but let's say it's 20, 25. And if I was doing both, that's a substantial amount, especially if I'm doing the upper face as well. And my approach to Botox is do everything heavy-handed. I don't want to see the patient for 4 to 6 months. What I tend to find with the Botox for the masseter and the parotid, that sometimes they can go out to around about 6 months. And then I just got to work out how to get them back in so that I've got a happy medium. So sometimes they miss the parotid and the masseter, and then I get them on their second hit. I tend to drop my dose for masseter and parotid, but keep the dose per unit high for cosmetic. And they come back. They see the results. They're not going to skimp on it.
Yeah, that's a really good point. If we are trying to avoid the rare risk of resistance, which I think we can all appreciate is very low, but not impossible, it's important to do your dosing together. So, you shouldn't have patients do upper face and then 3 weeks later decide they want their masseters. You either do it all together or you wait a minimum of 3 months for the next one. Have you seen any cases, or what's it like in Singapore where traditionally you guys might have been treating calves and other areas? Like what's your view on resistance rates in Asia?
Could I quickly just add something to the previous point, because I just think it's a nice point. I just find what Stefania says really interesting, because if there's such a thing, obviously we do what the patient needs, right? But I am more of a filler injector than a Botox injector. So I actually find that the Masseters opens the topic of having a slimmer face for me. So when my patient comes in and says, I want to do the slim face injection, I point out to them that it's not the angle of your jaw that's making your face look bulky. And so that opens the conversation of lifting the jowls, lifting the lower face. And on that same note, when do we not inject masseters because of the fear of the jowls? I used to have this rule whereby I don't inject anyone above 45, but I subsequently realized it's a little bit conservative. I'm now thinking that you can inject the masseter if it is indicated, so long as you treat the jowls first. So I inject the cheekbones, zygomatic arch, I inject the subzygomatic space posterior to the anterior border of the masseter. I lift the cheek, I lift the jowls, and then if I still need, I can inject then the masseter. So I think actually when the patient comes in and looks for a slimmer face, it is usually not just the masseter alone, unless she's really young, that's causing her face to look bulky, and it actually opens up the conversation to a lot of combination treatments. Okay, as for resistance, can I say what I truly feel?
Of course.
Is this, the stages that the three of us are on, we can't. I think that we have used for many years, we have used science to debunk pseudoscience. And why are we making such a big deal of Botox resistance when I haven't seen a single case in my entire career? I get that it's possible, and I get that scientifically it is sound, but I just haven't seen a single case practically. I asked around my friends, and I wonder if the cases of resistance that they send to me or just ask me for advice, I wonder, are they resistant to Botox, or was the Botox appropriately placed in the first place?
Yeah.
Because if you're not hitting the muscle, you're not going to get the results. If you're not hitting the muscle with the right dose, you're not going to get the longevity. So then, I think technically, we doctors, we like to think that we're all very, very good, but of course, when you start out, you don't have proper training, you're gonna have some mistakes, right? And if you didn't inject if you didn't inject properly, you're not going to get the results and the longevity that you want. So I think first and foremost, there's that. Secondly, true resistance, it's really, really hard to prove, because there are those scary numbers that after the Botox injection, you can find antibodies to Botox in the blood, all that kind of stuff. But the truth is, if you drew, this is not from me, by the way, this is from someone who actually knows science. Apparently, if you drew blood from yourself, spun it down, and injected your own albumin into your own body, your body would make antibodies to your own albumin. It's just an immunological response to anything that's injected. But to be immunized against something, like a vaccination, you need the body to remember that problem and create a stronger than usual immune response when it sees it again. And to prove that with Botox is really, really difficult. So I think a lot of Botox resistance is I don't know. It's I find it's a narrative. It's a narrative from people who may not just be talking about the problem itself.
Very diplomatically put. Well, we went into great detail on a podcast 1 or 2 episodes before with Dr. Stephen Weiner about all of this, and we sort of coined the term pseudo-resistance. So, yeah. So anyways, that concludes this episode. David is struggling here. I can see you're not well.
Oh, good. I'll survive.
You feeling right?
I'm good.
Okay, good. Well, thank you to our guests again for contributing. I really enjoyed that one. It was a sort of a slightly different one in our Tox Talks.
It's good.
It's always to learn about new techniques and new on-label stuff. And to dangle this, at some point, I hear that platysma is going to be on-label at some point with Botox. So maybe in the next year or 2, we can get you guys back if you launch it in China or somewhere else. Steph, maybe you'll launch it here in Australia. Who knows?
That'd be good. That'd be great. Well, thank you very much for having us here.
Thank you.
It's our pleasure. Well, Felix, I'll see you in a month and a half or so. I look forward to it. And it's my birthday, so you have to take me out for a beer when we're in New Zealand.
More than a beer. I think 1 beer is not enough. It's a birthday.
All right, guys. Thank you for your time.
Thank you.
Speak soon.
Thank you so much.
Bye.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.